Hello and good afternoon, good morning, good evening, wherever you are in the world. Thank you very much for joining me on this other topic about COVID-19 in South Africa and the Omicron update. There's not a lot to share because there's still a lot of research to be done, but we've got with us Dr. Shankara Chetty. Now, just to put it in context, in April of this year, I first spoke to him and I was blown away by his knowledge and what he had achieved at that time with over 4,000 COVID patients treated and zero deaths. He's now over 7,000. It's almost unbelievable. And there is so much to learn from listening to him and hearing from him. And so, with great pleasure, I welcome here Dr. Shankara Chetty. And Shankara, if I had a great applause sound, I would probably put it on now.
Yeah. Thanks for
uh,
having me again, Philip.
Excellent, excellent. How are you? Now, as I said, as I was saying, is that I do feel that since we had that interview in April, there were over, I think, probably 280,000 views of that video. You have been called all across the world to get involved in trying to help different countries. We're going to come to that in a minute. But I think that one of the strangest things that I have seen and I have observed many times from the comments is many people just don't believe it. They say it's not possible. Any thoughts about that?
Oh, I've had that too, Philip. I think the world has been too fixated on data and randomized clinical trials and the rest. I was having a discussion with Chris Newton, and I mentioned to him. I said, we science has gone astray a little bit. Uh, when you test, the pharmaceutical industry is what's brought in randomized clinical trials, and you usually have this bell-shaped curve when you test a new drug against society. And we focus on the center of this bell because we want to know what this drug does. But here we're dealing with the pandemic, and we've got a wealth of understanding before we even got to this virus. So when we deal with such, we still get a bell-shaped curve, but the center of the bell is well understood. It's what we expect from a respiratory virus. So what gives us the understanding is the tails of this bell-shaped curve, the unusual patients, the things that we didn't expect to see. And that's what brings new scientific discovery. So I think doctors need to go back to discussing the unusual cases in the doctor's lounge at the end of the day, and we'll find some breakthroughs in science. So I think, and I think as well, Philip, the simplicity of what I discovered is sometimes mesmerizing. It can't be that simple, can it?
Yeah, this is part of the problem is people just think it just can't be that simple. And we're going to come and discuss that in a little bit more detail. But I wanted to take a little time, Shankara, and I wanted people to understand the principles of simplicity of what it is that you've done. So here is a picture of you with your team, and it's just two nurses, isn't it?
Yeah, just two nurses. I employed a third when we get busy in the middle of the waves. Unfortunately, she is in high school. She does my screening at my front gate. And so I think with Omicron, she'll be coming back this holiday season to assist me.
And for those who want to see just the overview, so this is I have another picture here as to what you've put your spacing in place. You've got your tents. You said somebody tried to steal your tent, did they?
Yeah, yeah, yeah. I'm going to have to get a new one, especially for Omicron. The little one on the side. It's sunny South Africa, but I heard that sunshine's good for COVID. So thinking of whether I should get that tent or leave them out in the sun a little.
And there's a picture here with regards to the building that is just across the road. I'm just going to pull it up in a second here. So across the road, you can see your tent on the right here. This is where what is this tent here for?
Outside, Philip, I have to separate out COVID positives and COVID suspects. So
Mm-hmm.
that area is for COVID positive patients. If you look in the background there, all around my garden, you can see people trying to socially distance, sitting along the borders of my property. Uh, the other tent on the main tent is for examination, and then on the side I have a little pagoda there that's for COVID suspects. Those that are there for
Absolutely.
other reasons are allowed to enter the practice itself.
Wonderful, wonderful, wonderful. So I tell you what, Shankar. So let's just, for people who may never have heard you before, let's just do some very basic reminders as to what happened in April or May 2020 that made you do this unusual approach for which you still have had zero deaths.
Yes. I've had patients who were taken into hospital where either my treatment was stopped and they deteriorated, or patients taken into hospital where other treatments caused their demise. But as
Hmm.
far as my protocol goes and in outpatient treatment, all that stuck with me all recovered. And I've had some
Absolutely.
critically ill patients.
And you're pretty ill patient. So tell us about what happened in the initial phases of the pandemic, because I am going to be using that skillful thinking and analysis to look at in more details Omicron. So take us back to what caused you to look at COVID-19 differently at that time.
Philip, from the perspective of the virus, I know that humanity's been exposed to coronaviruses before, and I understood that kind of illness. So I had an expectation of the kind of picture, spread, epidemiology, that kind of thing. And so I was watching it before it even got to South Africa. And then I wanted to understand its presentation, the clinical picture. I needed to figure out how to treat this illness. And so I started looking at what was coming out of France at that time, I mean, Italy at that time. And the dyspnea was well reported. But remember, we're talking about clinical pictures of patients in hospital. And these are severely ill patients. So we knew about the saturation drops. We knew about happy hypoxia. So there were certain clinical signs and symptoms there that were unusual. We knew about the loss of smell and taste. But we were also hearing about people dropping dead on the road, on the streets. And that was very unusual. It was almost like you didn't know how ill you were, and suddenly it caught you by surprise. Uh, so I knew that I was going to be dealing with something unusual. And I needed to understand what was unusual. So the world was calling this a COVID pneumonia. And I thought that the education and understanding will come from examining the patient from the day he developed the disease itself to the presentation in hospital. I thought that was lacking in the pandemic itself. And so I decided, well, I need to fall back onto my education. And I decided to set up a tent. I decided to educate my community that there's no reason to fear. We will see them from the start. I took the necessary measures in setting up that tent so that I could triage patients. Ventilation and sunlight has always been the best disinfectants you could find, and so it was a simple task for me to make sure that I make myself available to patients. I needed to gain an understanding of what exactly was going on, and of course, I didn't want to attract the attention of the authorities, so. I moved out of my home into a flat so that I didn't. My home and practice are actually in the same premises. And so, to protect my family, I moved out into a flat into isolation. And I spent the first 4 months examining patients, living in isolation. But I took the time to examine every patient and try to understand how this disease progressed. In viral infections, they tend to have a very typical progression. It's unlike a bacterial infection that can last 2 days or 2 months. Viral infections have a finite time in their host, and like measles and chickenpox and all these kinds of viruses that we deal with. So I wanted to understand how this virus evolved to the point where it got to dyspnea and hospitalization. And so that was the aim of me doing this.
And it's an interesting point, Shankar. You said something there that really got me to reflect. You went in the front and you looked after patients trying to understand the presentation of the disease. Why is that kind of observational work no longer respected as much in the context of medicine?
I think, Philip, medicine has become too commercial, dictated by pharmaceutical companies, dictated by algorithms, dictated by protocols. I think in our interview, I mentioned that I treat patients and not blood test results. And I think it seemed to have resounded with the older doctors. The
Hmm.
younger guys are all taught to look at blood test results, and. So I think medicine has moved away from where it should have been, the clinical examination of patients, the understanding. And I think that's what doctors should be doing. Looking at patients and understanding the symptomatology. There's a wealth of knowledge that you get from examining a patient. In my practice, I've structured it such that I can watch a patient walk into my consulting room. I do not sit behind a desk. I could never talk to my principal from behind that desk. So I want patients to feel comfortable so that they could tell me all their problems. And of course, if someone's limping in and I was sitting behind a desk and I walked in while they were seated, I'd never know that they limped. So I think the examination of a patient starts well before you've even greeted that patient. And of course, the way a patient greets you, shakes your hand, makes eye contact, all these little nuances give you a great deal of information about the patient you're dealing with. And no blood tests or no amount of investigation will give you that kind of knowledge. And so if it comes down to your patient itself, you're going to have to take that route. No two people are the same, Philip.
Yeah, no,
And
absolutely.
I think we've got to respect that.
Yes, no, absolutely right. Because I realized the first time I spoke to you that what you had was a wealth of real life experience of seeing patients very, very early. Because in most other countries, doctors refuse to see the patients early. They would only end up in hospital. So we missed that critical phase of observing patients quite early on in the disease and trying to figure out what in the world was going on. And in that process, you came up with a very important observation called the eighth day. Can you just simply explain that to people?
Uh, when we started seeing the first cases of COVID, I had already had formulated an idea of what I might be dealing with. Uh, the progression of the illness, from what I'd seen in Italy, you were seeing people progress very rapidly. And then on the other end of the scale, you were getting people saying it's just a common flu and they don't understand all the hype. So there was this mix of cases that you were seeing and that spread of illness. So I knew that I needed to plot this carefully. And so I spoke to every patient. I explained to them that if their symptoms worsened, I need to know about it immediately. I wanted to ensure good clinical recovery and speed to that recovery and examine the dyspnea, understand what was bringing on this dyspnea. And initially, the first few patients that I saw had typical viral flu like illness, which after 3 or 4 days showed signs of remission, and they recovered without any event. And then I had the first patient that came in breathless. And of course, I needed to consider what to do at that point. We knew that this is a steroid responsive illness. And so that would be the ideal point to start the steroid. It was obvious something changed on that day. And so I started that patient on steroids, and it took a day or two for them to start to recover. And by about 3 days of steroids, they showed good signs of recovery. And then the second patient came in. And then I started to notice a pattern by about the third or fourth patient that every single one of these patients that came in exactly 1 week after the onset of symptoms. So I went back to my records and rechecked. And for all of them, it was the same. Every patient that developed breathlessness seemed to start developing that breathlessness a week after the onset of their symptoms. And of course, I questioned all those patients as to how they got to that point. And all of them were perfectly fine the day before. There was no progression. Pneumonia is a progressive illness. You start with a sore throat, it develops into a bronchitis, and then you start to notice breathlessness, and you've got a pneumonia. You're not perfectly fine and wake up one morning and you're breathless, and that's considered a pneumonia. So the illness itself didn't fit the diagnosis that I was hearing about from around the world. And the clinical examination of these patients were unusual. Pneumonias present with patients that are critically ill. These patients were not critically ill. They were fatigued, they were breathless, but otherwise fine. You'd never say that was a patient with a pneumonia. And then on examining those patients, they had good air entry into their lungs. Their breath sounds were normal. There were no crepitations that I could elicit from them, unlike a pneumonia. The only symptom from a respiratory perspective that I found was that they complained that they couldn't take a deep breath. That was all. And I found their saturations were decreasing. So straight away, that's not the typical clinical picture that you'd see with a pneumonia. And of course, it brought clarity that I was dealing with a biphasic illness. Something had changed on the 8th day. With all of them, they had shown signs of recovery in the first 7 days, and then suddenly worsened on the 8th day. And so I knew I'm dealing with a biphasic illness. It didn't seem to have any linearity to it. And of course, the second part didn't have any bearing on the first. There was no correlation between the two phases. I had patients who developed a sore throat, within 2 days recovered from that, spent the rest of the week perfectly fine, and exactly a week later, suddenly started to develop breathlessness. And that was strange. That's not the way typical pneumonias progress. And so I very early on realized I'm dealing with a different pathology here. And so I had to take the time to try and figure what that pathology actually is.
All I can say, Shankar, every time I listen to you speak about this, it sends the goosebumps of the fundamentals of medicine. That is proper medicine. Observe, reflect, apply, observe, reflect, apply. So this led you to observe the 8th day, and technically, this observation of the 8th day with the initiation of antihistamines and steroids caused you to save every single patient that you came across.
Yes, Philip. You see, look, as a doctor, every patient that comes in is a therapeutic trial. I don't know whether the medication is going to make them better. I rely on my skill to diagnose. And of course, the diagnosis is usually a differential diagnosis, and you treat the most appropriate. And if you fail, then you go to the second most appropriate and investigate further. So every patient is put through a therapeutic trial. And the success of that therapeutic trial is determined by two things: speed of regression of symptoms and complete recovery. So speed to recovery is vitally important. There's no point me giving you a paracetamol and waiting 5 days for your headache to disappear and then think that the paracetamol did something for you. There must be a quick response to the treatment. And in any treatment being a therapeutic trial, if we get quick response, speed to recovery, it will dictate or galvanize the underlying mechanism. So that's the way I practice medicine. And so I started with the steroids. I understood that I'm dealing with this diversity of reaction on that day as far as severity goes. And so the only thing that seemed to fit was an immune mediated response rather than a worsening viral infection. And so looking at that, I thought, well, if I'm dealing with an immune response, it looks like an allergen or some kind of hypersensitivity, then the addition of an antihistamine would be the logical next step. And so I think the fifth or sixth patient that came in, beside the steroid, I added an antihistamine and then compared speed to recovery. And where the steroid took me 3 days odd to see this recovery, with the addition of an antihistamine, it was the next day. Patient was fine. And so it hastened the speed to recovery. And so that drew my attention to the fact that I'm dealing with hypersensitivity. And from that point on, the science follows the education. We know what hypersensitivity does, the release of mediators, and what you're going to have to do to mop those up. And of course, my focus shifted to what the likely allergen might be, the culprit that's triggering this reaction.
Mhm.
At this point in time, every patient that I've treated has had the same kind of success. So I think the focus has shifted now from treating COVID to understanding what's causing it.
Somebody asked a question, which I know is important, is which steroid did you use? Because across the world they're using dexamethasone, but you're not using dexamethasone. Why is that?
Look, dexamethasone is an injectable, and being an outpatient facility, I don't have the facilities to set up drips and monitor all these patients. So I knew I needed a steroid, and of course, I have a great understanding of prednisone. It's a cheap medication, and I've used it for many years now. So I thought, well, I'll start with that. If I had difficulty, then there'd be a reason to change. And of course, I deal with some of my clientele are a very poor community, and prednisone is the cheapest steroid you could find out there. And so I decided I'll use prednisone as the start. And with the recoveries that I've had, I found no need to really change that. Yes, I in those patients who could afford it, I changed it to methylprednisolone simply because it has better deposition in the lung, and that's where the pathology is. And of course, slightly less hyperglycemic problems with it. I've had patients who were put onto dexamethasone in the hospital setting, and I advised, when they weren't recovering, I advised doctors to change it to either methylprednisolone or prednisone, and we saw a difference. So if I had to give you my opinion on which is best, I'd say methylprednisolone and prednisone are actually far more effective than dexamethasone, and easier to administer, and of course cheaper.
Absolutely, absolutely. So one of the other things that I know came out that I want to I'm kind of summarizing and reminding people of some very important things that you have done. Part of your strategy was education. You educated your patients as to what to expect, and this was part of the reason why your strategy was so successful. What exactly did you say to your patients?
Philip, that education goes on to this day. I think it's the most vital part of saving lives. Uh, I realized that things take a turn on the eighth day. And to plot that eighth day, it's vitally important to find the first day of illness, the day the illness started. Now, patients sometimes get confused with that. You ask a patient when they started to feel unwell, and they'll tell you, my cough started on this day, or my fever started on that day. But it's important to interrogate those symptoms so that you come to the exact onset of illness. So, my question usually would be, were you perfectly fine the day before? And then the patient will say, no, I started coughing, but the day before I started with a fever. And so, were you perfectly fine the day before that? And so, doing that plots the first day pretty accurately. And from using that, I educated every patient about a week later and what might transpire. Patients needed to understand that what happens on that eighth day is critical. So my initial treatment was to get them over the viral illness, which wasn't a difficult thing to do. We've all had viral illnesses, flus and respiratory illnesses. And so I made them do the usual. I ensured that they get over that initial phase before the eighth day. We do our best to get you to the eighth day, prepared to fight a war if it so be. And so
Mm.
everyone got educated about that on the eighth day, you better be well. You better do everything you can to get past the initial illness quickly. If there's worsening of symptoms, come timeously back so that we can adjust your treatment. And on the eighth day, if you have any new symptoms, I need to know about it immediately. In the first wave, it was breathlessness. So, I mean, a patient gets breathless, they're off to the doctor. Everyone knew about that. But in the second wave, I found that the presenting symptom on the eighth day wasn't breathlessness, but more fatigue. And so I had to educate patients about that if on the eighth day, you were perfectly fine on the seventh day, and on the eighth day, you got up with this overwhelming sense of fatigue, that's enough to present back to me. And of course, they understood the gravity. I think there was enough fear in the world for them to understand that they need to come back to me on the eighth day. I didn't need to make them any more afraid of what's going to transpire. And so they presented back timeously. You see, I think the problem with this, Philip, is unlike other allergic reactions that are clearly obvious, you know something's wrong and you get to the doctor. This was an allergic reaction triggered in your lungs. And of course, the lungs have a 2/3 residual capacity. And so it might take a while for you to realize how critically ill you actually are. And that waste of time in getting to treatment makes it so much more difficult to curtail the process. We know that with severe anaphylactic, anaphylactoid kind of reactions, the speed and aggression with which you address them is vitally important. And so I needed to make sure that when patients had this reaction, they came back timelessly. And to do that, so the education about the 8th day was vital. I had some assistance from a few priests in my neighborhood. Unfortunately, they developed COVID. And we went through the same chat about the 8th day. And all three of them recovered and had worsening on the 8th day and rushed off back to me. And of course, I was given the opportunity to start aggressive early treatment, and all three of them recovered. And then I think, when you predict the day that someone's going to start to die, it's almost biblical. And being a priest, they looked at me like, geez, this guy must be a holy man. He told us when we're going to start to die. And so they went back to their congregations and started to educate them about this phenomenon. And so in my area, the 8th day became a talking point very early on. And that was a good thing because the population around me understood that the 8th day is vitally important. I had uneducated patients, really illiterate patients, sitting and waiting for me in that tent that you saw. And I would hear them telling other patients about the significance of the 8th day, and they mustn't ignore it. So the word spread amongst the population very early.
Absolutely. No. So Shankara, so as I said, I spoke with you in April, and then you kind of went viral, and lots of people heard about you. And in a strange way, similar to what is happening with social media here, people are raising awareness of what you're doing to their clinicians. It's a strange thing that it's not the clinicians who are being taught about you, but the general public are saying, we need to know what you are doing so we can be protected. But there have been countries that have come to you, haven't there?
Yes, Philip. Very initially after the interview, the first it was MAFM, the Malaysian Translational Medical Association, contacted me, and they wanted me to come and train doctors. Via the internet, we're in lockdown, and so we set up a meeting where I could educate doctors about the perspective and how to plot the illness and how to initiate treatment. And in that first meeting, we had 183 doctors sitting. After that, the association took that meeting, which lasted, I think, 3.5 hours, and cut it up into pieces and put it onto their website as a training course for doctors around the world, so that any doctor could log in and understand the perspective. And so that provided me an opportunity to have a broader audience, even without my presence. And a few weeks after that, I got a call from the Secretary of Health in Meghalaya, a state north of India, and he wanted me to train the doctors there. We had that initial meeting. What he did was to invite all the heads of departments to sit in and understand this new perspective. And so that initial meeting was to the head of Obs and Gynae and the ICU. And so I gave them a rundown of how to plot this illness and how we should be seeing this. 2 weeks later, I was called by them again to say that I should please come back to train the rural doctors in Meghalaya. And the ICU specialist that I had spoken to 2 weeks prior wanted to give testimonial before the start of that training session. And he said, look, from the understanding of the perspective, he instituted it in his ICU. And just by changing the approach to the patients in his ICU, understanding that we're dealing with a hypersensitivity pneumonitis rather than a COVID pneumonia, he managed to avert 3 out of 4 intubations in his ICU. And he found that remarkable. And he also said that his grandmom had come in. She was 84 years old. She had come in on the 13th day with the saturation, I think, of in the 60%, if I remember correctly. And they were all very concerned about her because she was diabetic. But he did as I had taught him to. And on that day I was presenting, it was their 5th day in hospital. Her saturations were now up to 98%. Her biomarkers had all stabilized, and they were waiting for her last blood test result. And he was hopeful that she'd be discharged the next day. And I think this realization of how simple it can be to reverse the problem, he decided that, look, he shouldn't be having patients come into his ICU in that critical condition. And this information needed to be passed on to the rural doctors so that they could prevent it and prevent patients from actually getting into hospital in the first place. And so I was called in to actually teach all the rural doctors. That has moved on. I've trained doctors in Sri Lanka. I've now had a workshop in Singapore as well to train doctors there. I've had various doctors around the world contact me for information about how to do this. But the first subset of doctors was in India. Before our interview, Philip, I shared this with the chat group of my colleagues, my final year students in my class, my classmates. And it was a revelation to them. We spent 3 weeks discussing the perspective, the ins and outs of what I had found. And so it started being used in India very early on, long before any other country heard about this. So I've got a lot of my colleagues in India who've been using this, and we get the testimonials from them as well. I think this is not about the numbers. It's not about how many patients' lives I've saved. I can't do it all with my two hands. And the more people rally around me and understand the perspective and take it along and save lives, that's my interest. And so I've tried to stay out of the governance structures. I knew that there'd be stumbling blocks down that road. So the aim was always to enlighten doctors about my perspective and educate patients. And I think if those two subsets of community understood, I didn't have to ask anyone's permission to save someone's life. And so that was the basis of my push from the time we had our interview.
And you've also had some success with colleagues in South Africa as well, haven't you?
Yes, in South Africa, unfortunately, South Africa's been the last country to respond to all my work. A colleague in Durban, a doctor that, I was unaware of, he heard about my work through the international acclaim it was getting. And so I think he thought that he needs to check this out. He was almost doing this in disbelief. He's an ICU-trained doctor who's been seeing COVID for the first two waves, but on an outpatient basis. When hospitals were too full, or those patients that refused to go to hospital, he was called in. And he used the World Health Organization protocols and tried all the other little protocols that were out there with anticoagulation and the rest. And when he heard about my protocol, he tried to contact me. And of course, it had gotten to a point where I was wary of entrapment because I was getting this eerie silence here in South Africa. And so my wife deleted his emails. She said, "Who's this doctor asking you about treating the patient? You don't go and give him advice and have him blame you for anything he hasn't done correctly." And then he got my cell phone number and contacted me, and we had a chat. And he realized that I was right in the methodology of treatment in the first 4 patients. The first 2 he had seen in the third wave. I think he was skeptical about trying this, so he hospitalized the first 2 critically ill patients. And then the following 2, he decided to try this methodology. And the very next day, they were feeling a lot better. They had drastically improved. So he contacted the hospital for the 2 patients he had admitted and insisted they change the treatment. And they were discharged in 2 days. And so he felt he needs to discuss this with me. And I mean, it's a simple perspective if you're treating hypersensitivity or an allergic reaction. So I explained the perspective to him. I educated him about all the little nuances that we had. And he took that further. And in the third wave, he'd gotten through over 1,000 patients in that time. And at the end of the third wave, we took the opportunity to look back and see where we'd come in this journey. And in the first and second wave, remember, this is the doctor seeing critically ill patients. He had an average of around 1 to 2 deaths for every 10 patients that he had saw. And in the third wave, he had gotten through over 1,000 patients and not had a single death. He was so thankful to me that I had curtailed the mortality in his practice. When I had met him, he was traumatized. He had a staff member that passed away. He had an intern that passed away. And he's up to this day so thankful that he hasn't had any death in his practice. But of course, It might be my hand. It might be a new variant. All these things come up with people in disbelief. And so I sat with him one day and I said, look, speed to recovery is what I look at. Let's take two patients similarly ill and consider the different modalities of treatment and how quickly they recover from it. And so we took a patient with a saturation of 70% as our baseline. And he said, look, in the first and second wave, he did the steroids, the tocilizumab, the remdesivir, and it took an average of about 3 days for that patient to improve from 70% to 75%. And a lot of patients went in the other direction and required ventilation. And in the third wave, he started using this perspective with antihistamines and montelukast and a high dose steroid to curtail the reaction. And he found that patients with a 70% saturation improved to 85% in a period of 4 hours. And in another 4 to 6, they had improved to over 90%. So I laughed and I explained to him, I said, well, now you understand why I negated the need for oxygen. The reversal of hypoxia was timeless enough not for me to go and invest in oxygen. We had a laugh because he sent me a message not too long ago on WhatsApp to say, in the first wave, everyone spoke of oxygen. And so I ran out and I spent the first wave chasing oxygen. In the second wave, it was remdesivir. And I ran out and I spent the second wave chasing remdesivir. So in preparation for the third, I invested 100,000 rands in oxygen and 100,000 rands in remdesivir. And he said, and then I met you. And now at the end of the third wave, I've got 100,000 rands of both lying in the corner of my practice unused. I need to find a doctor who's still treating this the whole way to offload it on me.
But on a serious note, Shankara, is that I think part of the problem is that people haven't listened to you. Sometimes they hear, a doctor has treated this many patients and zero deaths, and they just say, no, it's impossible. And they haven't listened, because anyone who listens to you speak knows you know what you're talking about. So can you explain, how is it that especially the Western world, with all of the financial power that they have, that they are not coming knocking on your door and trying to figure out how in the world can you do this? Why is this?
Philip, I think the Western world is too hung up on protocols. Is too hung up on following a specific methodology with treating people. And I think that's where the problem lies. You've got to examine every patient. Every patient's unique in front of you. And I think that's where the issue is. As well, I think that the governing structures have actually mandated protocols too heavily in the past. And so doctors have gotten used to just following and towing that line. I think as well, there's been a disconnect. Very early on in my career, Philip, because of my science background, I was offered registrar specialization posts in a lot of different specialities. And a lot of my peers thought it was a waste of my knowledge that I decided to remain a GP. But I felt that the broad base of understanding was more important to me. I've had ophthalmologists figure out how to take a patient's blood pressure because they haven't done that in a while. So I wanted to keep this broad base to my understanding, and that's how I practice medicine. So I understand that sometimes the run-of-the-mill GP might find this daunting, because GPs tend to be a sorting station, and when things get a little too complicated, we send them off to specialists, and then specialists are generally sitting in a hospital without really taking understanding the patient and the family dynamics. I think all that comes into play. And I think we need to go back to basic medicine, understanding the patient in front of you, the science. I still have a lot of passion for science and nature and understanding that kind of thing. I still repair my own motorbikes, and I'm a very mechanically minded kind of person. So yeah, I've stuck my finger in a socket too many times and got shocked. So I understand science is my playground, and I think it's just that passion that shines through in understanding this illness.
So listen, I built the base because I wanted to make it clear to people that you know what you're talking about, And your insights are extremely valuable. So it leads us right into the question of Omicron, because here we are potentially at the beginning of the pandemic again. Because if this virus evades all of the vaccines, which is possible, we technically are right at the beginning, 2 years ago, almost December. This is when the pandemic started in December 2019. And we are now December 21, and we could potentially be all the way back. The first question is thoughts on what is happening in South Africa. I mean, it's very early, and you guys have almost been, what's the word for it? You've been punished for doing research by identifying the variant. However, it does seem as though most of the cases are in South Africa. So I guess some people could assume, therefore, that it is therefore the likely place where it came from. Any thoughts?
Oh, Philip, I think when you look at the transmission of a virus and the number of cases, we got to look at how we come to that. Other countries have lockdowns that are strictly instituted. South Africa doesn't. So there's the opportunity for more spread. Of course, we got a faulty PCR test. And so those countries that test everyone that's there will probably find more cases. So I think all these little nuances play into it. So we can't really say that Omicron originated in South Africa. We might have more cases. I think one of the first cases was found in Botswana,
Hmm.
and then a case in Hong Kong.
Hmm.
So yeah, this is an airborne virus. We never know.
Hmm.
Yes, we identified it to understand if we're dealing with something new, we need to get the science behind it and understand what's coming. But whoever found it is really irrelevant. There's no borders to the spread of air. So
Hmm.
I think the thing is the understanding of what Omicron is and how it's changed, how it's mutated, how it presents, and where we're going with this is far more important. The fact that South Africa identified it, look, we have a very good infrastructure here of genetic sequencing, understanding infectious diseases. We in Africa, we're prone to that. We have a large proportion of the population that has HIV. We're prone to having other illnesses, infectious illnesses. So our infrastructure for understanding infectious disease is quite advanced. And so I didn't expect that we would be admonished for being advanced. So yeah, that's I
That's
guess
just
that's
what
what it
it
is.
is.
Yeah, yeah.
So I have here a paper that was just recently published in the Lancet. I'm trying to remember who had done the paper. It was just a comment, really. And there's this graph here that I think you can see, where it's comparing the different the other variants, the alpha, the delta, and showing the trajectory here for all of them. Delta being the one that spiked the highest. But here you have Omicron, and you can see immediately that the trajectory here is very different from those of the other variants. And so we do have to be prepared for the fact that this is far more transmissible than any of the other ones, and therefore it's unlikely to be able to be stopped, even if we try and restrict across the world. So we do have to be prepared, I think, for the fact that this virus is going to spread. Any thoughts about that?
Uh, in the general evolution of a pandemic, Philip, the variants that evolve tend to over time become more they tend to cause less illness, milder symptoms, but tend to be more contagious. The aim of of a virus is to spread. I don't think a dead host benefits it in any way. So the illness tends to become milder, but the contagiousness of the virus itself increases over time. So there will be that natural selection for more contagious variants because they'll spread faster through the population itself. And that would be the natural progression of a pandemic. So it would start with all the fear and severe illness, and then it would slowly progress towards endemicity, being a mild illness that is transient but highly contagious and spreads quickly. So, yes, we're dealing with a far more contagious variant, but we're dealing with milder illness for now. There's a lot still to be learned. As far as the public health measures go, I haven't seen the benefit of them from the start. So, when lockdowns haven't worked, I don't think we can lock down any tighter, can we? So even a more contagious variant ain't gonna benefit from nonsensical healthcare measures. It's a respiratory virus, so it's airborne. It's spread through aerosols. We got to consider all these facts in our public health strategy. And so I think, yes, restrict large gatherings, restrict close contact, make sure people understand the sanitation and all that kind of thing. But hard lockdowns, restriction of travel, all that kind of thing, I don't think is going to make a big difference. But we're definitely dealing with a far more contagious variant. That doesn't mean that it's a bad omen.
That's a very good point. I think that, and this is where I'll mention some of my research with regards to autoimmunity, which is that similar to what you say, hypersensitivity, autoimmunity, they're very similar concepts in terms of the trigger. And my point was that the virus itself, or the viral infection, has never really been the major problem, as we can see, and up to the eighth day. That's when the viral loads had peaked. People are generally okay. When they deteriorate is about the immune response to the virus. Well, that bit is a bit more unpredictable. Now, the question is, if we have a more transmissible virus, are we going to have more cases of hyperimmune activation, which is technically what causes death in COVID-19? It's never a viral pneumonia. It's about the body's response to the virus.
Yes, Philip. With this, like I'd seen in the second wave, we had a mutation in spike protein, which caused it to be far more allergenic. And because of that increase in allergenicity, we had far more mortality and morbidity. So the pathogenicity of the variant was determined by its ability to trigger an inappropriate host response, and the severity of that response determined the severity or the mortality and morbidity of that particular variant. So now we got another mutation in spike protein. And of course, we're seeing mild illness with this. And of course, that fits in perfectly. That we probably now have spike protein that's less allergenic, and so causing milder illness, and you won't see the mortality and morbidity because you're not getting the same inappropriate immune response on the eighth day. Or it can be that even though we're dealing with a less allergenic spike protein, people might have developed a measure of tolerance towards it. And that as well will play a part in it. So it's the spike protein that is the primary pathogen of COVID illness, not the coronavirus itself. The coronavirus is just a vector to expose you to spike protein.
Yes.
Chasing the virus is really nonsensical.
Yeah. So an interesting question here from Ramon is about do your patients' symptoms differ based on their vaccination status?
Philip, that is something that I needed to look at very closely, and I found I could divide those patients into different subsets. On the eighth day, what we're dealing with is illness caused by spike protein. And so I classified that as spike protein illness because we're seeing it in a lot of different places. Post-vaccination, there's a lot of different places that I see spike protein causing problems. So I decided to call that spike protein illness. Now, what I saw was that with the mRNA vaccines, when it started in South Africa, I was getting a large number of patients coming to me 7 to 10 days post-vaccination with the onset of symptoms that seemed to be presenting like COVID. And a lot of these patients subsequently tested positive for COVID. Now, that seemed very unusual. And there were too many of them for this to be just coincidental. In those patients, I noticed a few that deteriorated 3 or 4 days into the illness suddenly. And that never happened prior to vaccination. And it was only in those patients that had taken the vaccine that presented a week to 10 days after that had this potential to deteriorate very quickly. And so I realized that I'm not dealing with a viral illness in some patients, I'm dealing with spike protein illness. So the vaccine was causing the body to produce spike protein. And on a specific day, that spike protein was triggering an illness similar to what I was seeing on the eighth day. And so the patient, 3 days into illness, that suddenly showed signs of deterioration with hypoxia, he wasn't actually on his third day of illness. His first day of illness was actually the eighth day. He went directly to spike protein illness and evaded a viral illness altogether. And so I had to watch that subset of patients. I had to inquire about every patient's vaccine status and exactly the day that they took their vaccine so that I could risk stratify patients appropriately. And so every patient that came in with that kind of symptom close onto vaccination, I did their biomarkers early because I needed to understand whether they were actually having an infection or whether they were just having an allergic response to the spike protein being produced in their bodies from the vaccine itself. And then those that presented generally a month after vaccination with illness, I could safely assume that that was a breakthrough infection.
Mm-hmm.
I had given them sufficient time to have an allergic reaction, and if they didn't, we had also given them sufficient time to have an immune response with the vaccine itself. And so those were breakthrough infections. And the true breakthrough infections after vaccination presented in exactly the same way. They had the viral phase, showed some worsening on the eighth day, and exactly the same symptomatology. Yes, those that presented with that kind of breakthrough infection a month to two after vaccination did have milder symptoms. And a lot of them got through the second phase of the illness really uneventfully with treatment. But I think that has little to do with the immune response that this vaccine actually triggers. Because if it did trigger an immune response, they wouldn't have got the infection in the first place.
Mm-hmm.
I think it has more to do with the exposure to spike protein and the development of a measure of tolerance to it. And so on the eighth day, when you're re-exposed to spike protein, because you've been desensitized, you don't have such a severe reaction. And of course, we've seen that claimed decrease in severity of illness and death from the vaccines itself tended to wane 3 or 4 months after vaccination. So I think once the vaccine has stopped making spike protein and you're no more exposed to it, then the measure of tolerance it provided you starts to wane. And so if you get infected after a period, you don't have that desensitization providing you that advantage anymore. And so you have a severe reaction to the virus again. And so the repeated vaccinations in decreasing severe illness and death is more out of desensitization or building tolerance rather than any immune mediated benefit to preventing you getting the infection in the first place.
Mm-hmm.
It's more a
Inter-
therapeutic benefit that I see.
yes, interesting, interesting. One of the other thoughts that I was having as I was reflecting, I was doing some research around interferon. And for those who are not aware, interferon is probably our most important defense against a virus because it stops the cells in the body from making proteins, which is what a virus needs to replicate itself. So when interferon goes up, it then blocks the virus from replicating, and the rest of the immune system can pick up the infected cells. Now, one of the questions I was wondering about is especially in the context of when people have, say, had their boosters and they've had a very, very strong immune response, the interferon has to be suppressed. And if interferon is suppressed and you then get infected, I'm trying to work out now, well, does that make it more difficult for your airway to clear the virus if it's already evading the vaccine antibodies? And do you then get a more prolonged infection? And if you do, what is the knock-on effect on that? And these are, I'm trying to think it out, and I think that it's definitely going to need your observation to try and see if there are any kind of patterns that come up, because I do expect this is going to present differently. It'll either disappear, as we hope, or it will present in a different way.
Exactly, Philip. Look, I trust natural immunity. I have no reason not to. And natural immunity has this broad diversity. The mechanism is that you take this virus and you chop it up into 100 different pieces and develop an immune response to each one of them. So you've got a large ambit of antibodies to fight the virus from a natural infection, and that is unvaccinated. Now, the problem is when you take a vaccine, especially a vaccine that is very specific for the wild type spike protein, you're giving a very narrow band of antibody response. And the antibody response is to a spike protein that doesn't exist anymore. And so we're dealing with non-neutralizing antibodies or non-sterilizing immunity. And yes, that's going to create its own set of problems. We might have escape variants and all that showing up. But what my concern is that a patient that's taken the vaccine, when faced with the natural infection, might not develop the same robust, broad, diverse, natural immune response to this virus that an unvaccinated person would. And so vaccinated patients might be prone to reinfection because they haven't actually developed a full, broad arsenal of antibodies to fight off a second infection. And that's the reason I think we need to be very cautious of how we collect the data. People that took 2 jabs and have now passed the sell-by date of those jabs can't be reclassified as unvaccinated. If they're classified as unvaccinated, then they're going to dilute or disrupt that pool of data of natural infection in the unvaccinated. So patients that have been vaccinated, and if they want to take a booster, have to be classified as something else, that they have taken the vaccine. Now, suddenly 2 doses later, 6 months down the line, you're calling those patients unvaccinated, but they have been vaccinated, and they'll have long-term implications of that vaccine. And so we're dealing with 4 subsets of patients, actually. We have those that are naive and never had an infection. We have those that had an infection and have developed good immune response. We have in the vaccinated group those that are naive and have never come into contact with this virus and are being vaccinated. And we have those that have had a response to a natural infection and then taken the vaccine. So there's 4 different subsets of patients there to have a look at, to understand what is the vaccine actually doing. Would the vaccine actually damage a natural immune response? You got through the virus, you developed a good natural response to it, and then you took a vaccine. Would that injure your immunity that you've actually developed to it? And until we recognize and acknowledge natural immunity and the role it plays, we ain't going to understand these differences.
Yeah, it's a very, very important point. And I think part of the difficulty, even though we're talking about this, I still feel very cautious whenever I speak about anything related to a vaccine, even to try and think it out, because there is so much censorship at the moment. But it doesn't allow you, therefore, to really think and try and analyze what the outcomes could be. You know, we all hope that everything is okay, but my perspective has always been we need contingencies in case things are not okay, and trying to see if we can come up with a strategy. And so this is really what I want to try and challenge your brain on now, Shankara. Suppose we start seeing quite severe disease. What would you start to think? What would you be looking for with your analytic mind?
Philip, it would depend on the patient, their vaccination status. I think that's going to play the most important part in this. We know about antibody-dependent enhancement. We know about the problems that vaccinating in a pandemic can bring. We know about the variants that might evolve from this. I know that spike protein is the pathogen here. And so I understand that changes in spike protein is what influences the severity of the illness. So I think the vaccine status of the patient is vitally important in understanding what's going to happen. And I've seen very distinct differences. Yes, early on, we've seen that vaccinated patients present with far less severe illness and less propensity to end up in hospital. But I do understand that that's the measure of tolerance which would fade after a period of time. So I think as vaccinated patients and unvaccinated get exposed to different variants, we'll be able to tell the robustness of the immune stimulation either through natural infection or through vaccines and how that influences the outcomes. So the severity of the illness that we see must be measured against the pre-existing immune status of that patient, be it through previous natural infection or vaccine induced.
Yes, it is. It is quite a complex situation, and it's one that I step back from as I reflect. And an important point that I think we're seeing across the world is that because of the Omicron, people are trying to get their boosters in. They're trying to get the vaccines in. But whichever way we take it, the speed of spread of this virus, 30 to 60 days. Um, and how long will it take to build a robust immune response, even at 3 weeks? So 3 weeks is 21 days plus 14 days beyond that for the immune system to properly be active. So you're talking about 35 days. And so there's all of this built into the picture. Plus, as I mentioned, about the interferon suppression, which could have an impact. So this is a very complex scenario. And my instinct is that we are actually in a more complicated situation 2 years down the line than we were before. Um, I think I've temporarily lost Shankara. I hope he'll jump back in. But yes, it's an important point that I was saying is that are we in a more complicated situation now, where we have a very transmissible virus? Um, than we were 2 years ago when we had a virus that was transmissible, but not as transmissible as this one. What should we do now? Should we repeat the same pattern that we did 2 years ago? Or is it an opportunity for us to look at things in a different way? These are all very, very important questions that we'll need to answer. And it's not easy for the public health authorities to make decisions because there is so much information that we don't know. We truthfully, even in the context of Omicron, from the 25th of November to the 4th of December now, that is still only 9 days. And based on the trajectory that occurs with regards to COVID-19, you can then see a difference in terms of how, because there's a delay in the immune response. So I think I've managed to get Shankara back again. I don't know what happened to you there.
We got a power failure, Philip. I think we typically South African load shedding.
Yes. Well, we're glad to have you back. Well, we're close to the end of our discussion because the two things I wanted to discuss with you before we close. One of them is that I wanted to raise awareness of your involvement in a very, very interesting organization, Doctors for the World. Um, you are now part of that, and you're part of the executive team in that. What about that is interesting to you?
I think, Philip, the medical care around the world has diversified.
Mhm.
It's taken on a whole different. It's an whole different animal today, and so we got all these different players that actually have bearing on healthcare and the way we provide healthcare to the population itself. And I think that there needs to be some parity. Pharmaceutical industry has dictated financing, and in so doing, dictated the direction in research, the direction of treatment. And I think we need some grounding, some understanding that all the different fields of medicine need to be weighted equally and given equal opportunity, because at the end of the day, the patient in front of me is the representation of humanity. And whatever interventions we take need to benefit the patient in front of me. And if they don't, then they don't benefit humanity. And what
Mhm.
attracts me to Doctors Federation for the World is that it gives us this broad ambit of uh, language, cultures, taking into consideration traditions, taking into consideration the media, the governmental structures, and how they influence healthcare delivery. So, Doctors for the World has strived to bring the wide diversity of the social strata together, all in an attempt to benefit healthcare. And
Mhm.
I think that's what's important, to not be directed by who holds the finances. And I think that's where Doctors for the World has been an interesting new development. I hope that we take it to a point where it becomes an organization that gains an advisory capacity to any global health intervention in future uh, from an ethical perspective. I think that's what we
Absolutely.
need to bring back into the medical interventions on a population scale.
Wonderful, wonderful. Yes, I agree. And for those who may be interested with Doctors for the World, we're going to be sharing more information about it quite soon. And we want to raise awareness. It's just a collaboration of clinicians from every part of the world, four different languages, learning and sharing with each other about different techniques in terms of COVID and moving on to other diseases in the future. So it's a very exciting project and one that will keep people updated on. So as we close out, Shankara, what are your thoughts with regards to where we are now? Because I was saying the point. Are we technically at the beginning where we were 2 years ago, but in a worse position, or are we in a better position now? Any thoughts?
Philip, I was asked this question at the start of the pandemic when I first published the article that was so controversial because it negated the need for vaccinations because we could save lives with early treatment. And someone asked me, what would you consider the best vaccine? And I said, well, the best vaccine would be to take the mildest strain of coronavirus and create a live attenuated vaccine. And of course, that would cause the mildest illness. And being a live vaccine, we didn't have to vaccinate everyone. It would be self-spreading. And it would almost create an artificial pandemic, and everyone would develop natural immunity. And so we'd put an end to the crisis. Of course, we've gone down the mRNA route or the viral vector route with a very narrow-based immunity. And with the Omicron variant coming into play, if it has the mild illness like we've seen, and we don't experience any complications from it in future, being as contagious as it could do the same job as a live attenuated vaccine in that
Mhm.
it would spread, it would infect large swathes of the community without causing any mortality and morbidity. And in so doing, get us to the herd immunity we so desperately desire. And of course, the vaccines aren't going to get us there. And so,
Mhm.
in that sense, there is hope. But as well, I think we need to be very cautious. We've seen this virus behave very strangely in the past, and of course, we need to be very cautious about the type of illness that it presents with and the long-term effects that it might have. And so, I think we need to be cautiously optimistic. If anything, those countries that have far more lethal, contagious variants should look at Omicron, if all pans out to be correct, as a blessing in disguise. And so the closure of borders and ostracizing South Africa might be another shot in your foot unnecessarily.
Absolutely right. Absolutely right. Great way to end, Shankara. I really appreciate your knowledge. I am sure that the audience will appreciate it. We hope more and more clinicians, governments, organizations who can influence protocols and treatment will listen to these words and, most critically, save lives. That is essentially where we want to go for the future: save lives. So thank you very much again, Shankara, and I'm sure I'll speak to you again in the future. Have a great evening. And if you just hang on while we do this outro.
Thank
Thank
you.
you, everybody who has been with us, and look forward to our next conversation. We'll keep you updated.